Good afternoon, ladies and gentlemen, and welcome to Brookings India. It's always nice to have a full house, and we are privileged today to have the Tufts University with us. More so because it's a Tuesday afternoon and the air quality notwithstanding, but we ensure that we'll have a good, interesting and interactive program which has been well crafted, and we have eminent speakers for you. The Tufts Brookings Roundtable will start with its first panel discussion, and I'll introduce the panel to you. Dr. Harris Berman, Dean of the Tufts University, serves as the Dean and the Dean of the Tufts University of Medicine. He completed residency in international medicine and a fellowship in infectious disease at the Tufts Medical Center. Dr. Honorine Ward, professor at the Tufts University, is our second panelist. She completed her MBBS from the Christian Medical College and a postdoctoral training from the Tufts University. We also have with us Dr. Srinath Reddy, President of the Public Health Foundation of India. He was also the head of the Department of Cardiology at the All India Institute of Medical Sciences. Dr. Shamika Ravi, Director of Research, Brookings India, and she is also on the Prime Minister's Executive Economic Advisory Council. The panel will be moderated by Dr. Deborah Kochevar, Provost of the Tufts University. She holds a veterinary medicine degree from Texas University and a PhD in cellular and molecular biology from the University of Texas. The panel will discuss innovative approaches to addressing India's healthcare challenges, dealing with the shifting burden of disease. May I invite the panelists to the podium, please?
So thank you for that kind introduction, and we're delighted to be here, as has been said. I know that we have a group here in the audience today that consists of many of you who will know the details of what I'm about to say in the form of an introduction. Others from Tufts may not. And so I'd like to set up our discussion a little bit and then turn to our panelists and begin to ask some questions. So first, bear in mind that India has 18% of the world's population, and that many of the states in India have populations that are larger than large countries. So that's just a frame of reference. There are a couple of important pieces that I think we're going to refer to several times today that I wanted to just almost define for the group before we get started. The first is a landmark global burden of disease study. This study had 167 authors from the India State Level Disease Burden Initiative collaborators. And so it sought to provide accurate state-level estimates of disease burden and risk factors over time. The study provided estimates of 333 disease conditions and 84 risk factors for every state of India between 1990 and 2016. So these were data sets that had not previously really been available. And so the good news is that the study found that the per capita disease burden has dropped by about a third over the past 26 years in India. However, the magnitude and cause of disease burden and the risk factors vary greatly between the states, and that there's been a shift from dominance of non-communicable diseases and injuries over the traditional communicable, maternal, neonatal, and nutritional diseases. So that mapping of inequalities across the states and the presence of this study and those databases, I think, is going to be very important to the questions that we'll entertain today. The second item that I wanted to mention follows really and is very timely relative to that study, and that is the idea that there is need for better health care and that the shifting burden of disease makes the recent launch of the government program Ayushman Bharat, the National Health Protection Scheme, of particular significance. And so in August of 2018, as many as 28 of the state governments had signed MOUs with the National Health Protection Agency to implement this new strategy. Thousands of hospitals have offered to join the network of facilities that will provide services. The initial measure of the plan is to roughly cover 40% of the total population at the lower socioeconomic levels. And another component of the new system is to expand the primary, preventive, and promotive care network. So in a country as large and as complex as India, it almost dwarfs our US concept of affordable health care. We thought that's a very complex program in the US, but I think clearly India has embarked on an equally challenging implementation period. So with that as just a little bit of background, our distinguished panel of experts today will consider healthcare challenges in India and the US with a focus in 3 areas: public health, finances, and research that addresses gaps in healthcare. And so you've already had a brief introduction to the panelists, so I won't repeat that. But I will ask each panelist to start with about a 5-minute introduction of their perspectives in this area of public health, finance of healthcare, and research. When they're finished, we will do some questions with the panel and then open the session up to questions from the audience. So with that, Shamika, would you like to start?
So good afternoon, everyone. My personal welcome to each of you to Brookings India. Health as a subject of inquiry in terms of public research, public policy research in Brookings India has been one of our core foundational verticals. So we have been looking at various different elements of public health and how we can impact policy through research. Now, we have Dr. Srinath Reddy on the panel, who has been a champion of universal healthcare in India for the last decade and a half. And I think one of the big challenges in the Indian situation is, the out-of-pocket burden of healthcare in India remains significantly high if we compare ourselves even to the BRICS countries. I'm not comparing to the OECD necessarily, but if we compare with our neighbors, for instance, with Thailand at 11%, China at 36%, India has an out-of-pocket health burden, which was 67 and has now fallen to about 63%, but it still remains significantly high. The second statistics which I think forces us to make health a priority is the fact that 7% of the Indian population falls below the poverty line because of a health shock. And that in absolute numbers is actually a very large number, given the 1.3 billion population. And the third fact is that whichever way we calculate catastrophic health expenditure, whether you use a threshold of 10% of your monthly consumption expenditure going on health, 25% or 40%, we really have not managed to dent that burden on a household. So it is very important, therefore, to have focused on health becoming a public policy priority within the Indian larger growth story. Now, what complicates the story further is the fact that India really is a continent. If you consider the 29 states, each state has very different objectives, very different disease burdens. In fact, they have very different governance capacity. And at the end, a lot of public health problems in the states can be attributed to the level of governance in these states. So just to give you a sense of the variation, while 75% of healthcare needs of Indians are met from the private healthcare sector, this number has only marginally fallen in the last 10 years because the government has had a scheme like Janani Suraksha Yojana, because India is signatory to the Millennium Development Goal, Sustainable Development Goal now, where maternal health is one of the indicators and child health, infant mortality is one of the indicators which we are required to bring down to a certain level. Now, the concerted effort towards attaining those objectives have been in the form of various policy announcements since 2005. And Janani Suraksha Yojana was one of them, as a result of which the emphasis or the utilization of public care has increased over the last 14 years. But still, we have not managed to seriously move people away from this reliance on a relatively unregulated, though growing, private sector. And the public sector utilization also varies greatly throughout the country. In fact, if you look at some of the more progressive southern states, then you have across quintile groups of the population, meaning rich as well as poor, about 75% of people are using public care for their needs. And that means public care is working in those states. But if you go to the states which do have governance problems, UP, Bihar, etc., then you have less than 15% across quintile groups who actually go to public care. So it is not true that public care is for the poor and private care is for the rich. It really is a matter of governance. And given the variation in the good governance or the quality of governance, particularly in public health, this problem is far more complicated when you look at the state level. I'm happy to get into the details of Ayushman Bharat as we go along, but that was just to lay the land, give you a sense of where we are in terms of public health care in India.
Thank you very much. So next.
Good afternoon. I'm Harris Berman. I'm not going to talk from an academic point of view. I'm going to talk from an observational point of view. I've had the unique opportunity to be observing India for over 50 years. My very first professional job was to come to India for 2 years as a doctor for the Peace Corps. President John Kennedy had established the Peace Corps in 1961. I was in medical school at the time, and that, as soon as I heard about that, I said, I got to do that. And the first time you could do it was after you finished medical school and internship and had a medical license. And I applied to the Peace Corps. They asked what countries I'd like to go to. India was number 1 on my list. And my wife and I, we were newlyweds, came here for 2 years, lived here in New Delhi, and my job was to take care of 1,500 Peace Corps volunteers who were in villages all over the country. So I got to travel a great deal and to observe the country, but also to look at the medical system in some depth, because I would visit the volunteers in their villages, and then I'd seek out where the best medical care for them would be, so they knew where to go if they got sick, and the doctors there knew who they were and knew to call me if there were serious issues. So I just want to tell you what observations about public health I made when I first came here. First of all, at every bus stop in New Delhi, there was a big sign, a yellow and black sign, a picture of a mother and a father holding the hands of 2 little children. And this was a family planning advertisement. And clearly one of the big public health issues of India was, and still is, its tremendous population. When we were here, the population was 700 million. It's now almost double that. But probably without the public health efforts, it would have been triple that. So that's obviously an ongoing challenge, but it was a big challenge then to get people to think about birth control. The other thing that was obvious everywhere you went was the ravages of communicable diseases. At that time, a large percentage of people had smallpox scars on their faces, and these were the survivors. So smallpox was still ravaging the country. And when I visited hospitals, I had the opportunity to see patients with diseases that I had never seen in America, and in most cases would not see. So when I'd visit a hospital, frequently it would have a whole ward full of diphtheria cases, and a whole ward full of tetanus cases, and a whole ward full of typhoid cases. And in the case of infectious disease hospitals, I visited a number of them where in the courtyard in the middle of the hospital, there was a little house with bars on the windows, and it was where rabies patients were put to die. So I think the country's come a long way from that. They still have a lot of infectious diseases here. I don't know if these infectious disease hospitals still exist. I know when I went to visit the Christian Medical College in Vellore a few years ago, I was asking them about, do they have an infectious disease service? And they said to me, infectious disease is what we do. So it's obviously still a problem. But I think the fascinating thing is, as India has matured and has grown and succeeded, you now have a middle-class population as large as the middle-class population in America. And you're seeing the ravages of obesity, of diabetes, of hypertension, heart disease, the same diseases that we deal with from a public health point of view. And you're going to have to, and obviously that's a challenge for you. One of the big successes we've had in America with public health is to drastically reduce the number of people who smoke cigarettes. That's an opportunity here, obviously. The cigarette companies have done a good job selling tobacco here, and many more people smoke than we're used to seeing. And lastly, the air pollution here is obviously a problem, although I must say I was pleasantly surprised to see the sun every day here. I've traveled extensively in Asia, and there are plenty of places where you don't see the sun for months at a time. But the combination of the smoking and the air pollution obviously take their toll on heart disease, strokes, and respiratory diseases. So it'll be interesting to hear from your public health experts what they're doing about all this, and what are the areas that they see that they really can make a difference.
Hello, can you hear me? So good afternoon, ladies and gentlemen, and thank you to the Brookings Institute for hosting this this afternoon. My name is Honorine Ward, and as an example of collaborations between India in health, I would like to tell you a little bit about my story and how we have initiated and maintained health collaborations between Christian Medical College in Vellore, India, and Tufts. So I am privileged to be a part of both these institutions. I went to medical school at Christian Medical College, and I also started research training at CMC. When I finished my initial research training, my husband was coming to the US, to MIT to do a fellowship. And I asked my advisor and mentor at CMC, Dr. V.I. Mathan, some of you may know him, and I said, what can I do in Boston? And he said, go to Tufts. And he already had collaborations with people at Tufts, and this was 35 years ago. So I came to Tufts, and 35 years later, I'm still at Tufts in the departments of medicine at the medical school and public health, and at the vet school in Grafton. And I have an adjunct professorship at CMC, which I'm very proud of. Again, I've been very privileged to be able to have ongoing, long-lasting collaborations with CMC. My colleague, Gagandeep Kang, who's, we call her Cherry, she's currently executive director of the THSTI here in Delhi, Faridabad. So the two of us have collaborated for over 20 years, particularly on diarrheal diseases in young children and malnutrition. This panel is going to be discussing non-communicable diseases, but my work and our work is focused on infectious diseases, diarrheal diseases, and malnutrition. And malnutrition is a consequence of some of the infectious diarrheal diseases that we see. India still has a very high rate of stunting in children under the age of 5. And it's not clear what the causes are, but there are several consequences of malnutrition and stunting in India. it's known that stunting leads to poor growth, development, school ability, and jobs. So one of the areas that Cherian and I and our colleagues are working on is trying to find out, why the causes of stunting, and also why vaccines don't work as well in India as they do in other resource-limited countries. And one of the postulated reasons is alterations in the microbiome. So that is something that we are actively working on. Our research has been funded by the NIH in the US. We have 7 NIH research grants and 2 from the Bill and Melinda Gates Foundation. And we also have a very active and ongoing collaboration in education, training of CMC and Tufts students. Again, this is funded by the NIH. So this is just an example of how collaborations can work between India and other countries. And I think I'll stop there.
Good afternoon. I'm Srinath Reddy. I trained as a cardiologist in India and as an epidemiologist in Canada. And my work in public health, of course, now embraces virtually all of public health challenges that India has. And the foundation is committed to building broadband capacity in education, research, training, health system strengthening, as well as in advocacy for public health causes. As has been remarked in the introductory opening, the Public Health Foundation of India itself contributed to the Global Burden of Disease study. And the fact that India has a substantial, well-documented shift towards non-communicable diseases in terms of not only the mortality burden, but also the disability-adjusted life years is fairly clear now. But there is a huge variation across the states of India. There are states which are well advanced in epidemiological transition with a high burden of non-communicable diseases and mental illness. There are several states which are still very early in that progression and have still a continuing high burden of infectious diseases and high child and maternal mortality. So we will not look at India as one homogeneous picture, but we recognize that due to variability in the pace of demographic transition, of nutrition transition, and overall epidemiological transition, we will see a fairly variegate pattern across India. And of course, the social determinants of health also come in, where we see a considerable variation across income groups, educational groups, and even according to social status. Just as you have race in the United States, we have caste in India, and we see some of the differences spread out across these regions as well. But we also recognize that it's too early and certainly not very wise to write off infectious diseases and other problems. Indeed, I recall that the Surgeon General of the United States in 1969, in testimony to the Congress, said, "We can now close the book on infectious diseases." And as though in quick retribution, the HIV/AIDS epidemic struck. And now we know that with a variety of zoonotic diseases threatening to become pandemics with antimicrobial resistance, and we in India, we see a fair amount of drug-resistant tuberculosis now. Infectious diseases will remain actively on the public health agenda of the country. And there is definitely a convergence there as well, because these are global concerns as well, not merely that of India, and there is a great opportunity to collaborate. But certainly in the area of non-communicable diseases, which are indeed the dominant contributors to mortality and morbidity, especially premature mortality in India, with a high burden of mortality coming below the age of 70 years, unlike in the United States where most of the deaths come after 70 years. We have a huge developmental price to pay because of loss of productive lives in the prime of midlife. And therefore, we need to look at how best we can actually telescope our transition so that we can also advance to a stage where most of the damage done due to non-communicable diseases comes well after 70, preferably after 80 years, when people after a full and fulfilled life may then have a stroke or a cardiovascular event, but certainly not at the age of 40 or 50. We have been dealing with the various risk factors, which are, of course, globally well recognized and common to India as well. Tobacco control has been a major area of priorities in public health. We have achieved considerable success in recent years. We have a strong tobacco control legislation, though our taxation policy could certainly do better with a higher level of taxes on tobacco. There's been a reference made to air pollution, and I was asked to comment on it. Certainly, air pollution is a major challenge, and it's increasingly also now recognized to be contributing to a wide variety of non-communicable diseases, including cardiovascular events. But it is multifactorial in causation, right from vehicular emissions to construction dust to agricultural waste burning, garbage burning, and coal plants, and so on. And in a federal polity like India, where much of the action has to be at the level of the states, there is a greater need for center-state coordination in terms of forging a common political will to tackle some of these environmental challenges that we face. And that is where I believe we have to make further headway onwards. But recognizing the kind of challenges that the world is facing, even in tackling climate change, and having a coherent policy on that, it's not easy to get a complete political consensus on immediate action, even though the concerns may be common. But we hope we'll be able to advance there. So apart from the social determinants and the environmental determinants, we have to deal with the commercial determinants of health. And they are actually propelling the epidemic of non-communicable disease in the country, not just tobacco, but the kind of fast foods, sugar sweetened beverages, a variety of changes that are happening in our nutritional habits. These are some of the things that we need to counter as well, and that is where a big public health challenge does come in. But critically, the whole area of access to health, affordability of appropriate health care, all of these are important challenges in our country. And as has been again mentioned, Ayushman Bharat is a response to some of these challenges, because previously the National Rural Health Mission used to focus on maternal and child health and infectious diseases, but to the total exclusion of a number of conditions, including non-communicable diseases. Now the comprehensive primary health care, which is now being introduced as a part of our national health policy, and is going to be actually advanced through the health and wellness centers and the primary health care centers, does now include a wide array of health conditions, especially non-communicable diseases and mental health, which were missing earlier. And there is bound to be a fair amount of effort to bring diabetes, high blood pressure, common cancers into screening, but also an equal effort to try and prevent some of the risk factors from rising in the population. At the same time, obviously, people who have manifest clinical conditions will require care and maybe hospitalized care, and that is where the second element of Ayushman Bharat comes in, which is the health cost coverage for hospitalization for secondary or tertiary care for people who are poor or near poor, the bottom 40% of the population, where their costs can be covered for a wide variety of procedures, which include non-communicable diseases, but are not restricted to that. So there is a health system response that is happening now, but again, with variations across states, as is very typical of our federal polity. I will not dwell further on this because there is bound to be more questions to follow up, but I believe we are in a state where we are seeing a fair amount of transition in our health states, and therefore our health system as well as health policy will have to be respond much more urgently and effectively to these challenges, because we do have a huge mixed bag of challenges of undernutrition, of inappropriate overnutrition, as well as a variety of communicable as well as non-communicable diseases, and still a challenge of maternal and child health, despite a fairly remarkable decline in our child mortality in recent years. Our under 5 mortality is still 5 times that of Sri Lanka and China. And similarly, maternal mortality ratio, though our decline has exceeded the global average decline, is still unacceptably high. So we have a much ground to cover, and our health system has to rise to that challenge. And given the health workforce crisis we have, we need to really depend upon innovations like technology-enabled frontline health workers and others in order to try and address some of these challenges. And that's where research comes in, which is the third component.
Much. I think you can tell from what's already been said by the panelists just how deep the expertise is across this group for the discussion that we're having today. So I'd like to ask the panelists to consider sort of our first question, and that is, from your different perspectives, consider the commonalities and differences between the U.S. and India in healthcare challenges and how you see those. And we don't have to go in order. We can jump in. Everyone has a mic, so we don't even have to pass mics. But who would like to start that discussion?
Well, let me.
All right.
Well, I think we'd like to learn from the mistakes of the U.S. When it comes to public health in particular. And in more specifically, the financing instruments where insurance is seen as the ultimate funding or financing mechanism or the instrument of choice for public health. I think there is enough research, particularly in the economic space, which has established the moral hazard and adverse selection problems that is fundamental to insurance driving the financing of healthcare. And we have seen that there is a reason that the US spends about 18% of its GDP on health, while Singapore really spends only 4%, and they have almost identical health outcomes, which goes to say that it's not the amount of money you spend, but just the instrument and the way you spend it, in ways in which basic human incentives are taken into account. We do know that in the insurance finance models, there is very little incentive with the patient as well as the care, the healthcare provider, to really cut down costs. And so we do come up with the co-payments and deductibles and other ways of defining and sort of refining the instrument. But fundamentals of cost escalation still underline a lot of what the health insurance market has predicted. I think Singapore is a country from where we'd like to learn a bit, particularly because they do recognize health as a public good. They do recognize that markets do break down when it comes to financing, where a lot of the healthcare financing comes from a pot. It's like it's a pot of money where everyone contributes, so there is a savings element to it. And when there is a savings and everyone has that account, it's totally incentive compatible, where people are not constantly having to draw down upon with no cost repercussions. So it's incentive compatible, and I think in the Indian case, while we have strengthened the health insurance, the National Health Protection Scheme, which is the Ayushman Bharat, we do recognize that some states have experimented. For instance, Andhra Pradesh has experimented with health insurance almost 15 years before the Ayushman Bharat got announced. And we have a lot of lessons learned, what kind of IT systems to put in place, what kind of frauds are common in the system. So we know now broad ways of reducing the cost, but still we are open to experimentation when it comes to financing overall. So there is a talk of experimenting with health savings, looking at impact bonds, for instance, in healthcare. And we have Rajasthan, one of the states, where we have a health impact bond which is underway, and we are very curious to see what happens, because again, incentive compatible, most of the ground level innovations that are happening as far as these small hospitals or clinics are concerned is they are being incentivized to go out and get accreditation, which is not widespread in India. In fact, it's a very small self-selected group of hospitals which do have NABH accreditation. So it does go towards improving quality. So we are at a time where we are learning from many markets. But again, because health is a state subject, it is not a central federal government subject. A lot of the experimentation will happen at the state level. So there's a lot of lessons to be learned even within India from some of the different states. So I do think there is that commonality, which is insurance driving the US health financing, and something that we have to be extremely wary of. Thank you.
So I agree with you that India probably can benefit from watching what the United States has done in public health. I don't think you should watch the United States for what we've done on healthcare financing. We are not the right model. As you mentioned, we have by far the most expensive healthcare system in the world. Healthcare is the largest industry in America. It consumes almost 20% of the gross domestic product. Interestingly, a lot of that has to do with pricing and not usage. If you look at, if you compare us to, say, Switzerland or advanced countries in Europe, they use about the same number of services that we use. They just charge a lot less for them. Our doctors are very well paid. Our hospitals are well paid. Our clinics are well paid. And the incentives have been all wrong. The incentives are for a physician that the more you do, the more you get paid. So you're paid by the piece. And we're trying to change that, but that's not an easy change to make. And on the other hand, you talk about the need to control costs, and we all have a lot of waste in the system. But I think we know from the British experience, there's a certain base level that you have to put in of finances to make it work. So the National Health Service has had periods where it hasn't worked well because they've underfunded it. And then it's had periods when it's really worked very well because they've funded it adequately. And I think the big challenge for India is going to be how do you fund it adequately?
I think there are several areas where we could learn from each other, particularly the whole area of shifting a fair amount of healthcare responsibility to non-physician healthcare providers, nurse practitioners, physician assistants, and others, which in the US context has actually emerged more for cost saving. What is the virtue for the US is a necessity for us because we have a huge shortage of doctors and nurses, and particularly doctors and specialists. And there is a huge problem of access to health services in many parts of the country, rural areas, as well as some of the smaller towns. Now we recognize that a lot of primary health care and a good part of even hospital health care can be actually provided by technology-enabled non-physician healthcare providers with intermittent physician supervision or support. And therefore, this is the kind of model that we ought to be looking at. The second element, I think we ought to, despite all the problems of US healthcare financing, the fact remains that about 48 to 50% of healthcare expenditure in US is public financing. Whereas in India, with 25 to 30% of public financing, we are way behind. And there's no way we can actually move towards universal health coverage at that level of public financing. So one of the lessons is that even in the United States, which is a poster child of private healthcare, public financing plays a great role, and then we ought to learn that lesson here as well, even if we do not learn it from the UK NHS. The third area, of course, is that there is a great deal that we may be actually able to also provide to the United States in return, or other countries. There are so many innovations going on in this country because of how to bridge the access barriers. So a lot of innovative technologies are being developed. Low cost, high impact technologies are being developed. A lot of decision support systems, handheld tablets with auxiliary nurse midwives doing diabetes and hypertension management in communities with excellent results, and a number of other innovations that are coming up in the way of health care delivery, and even in terms of community engagement. So all of these experiences, if adequately evaluated and with potential scale up within the country, can also actually flow in a reverse innovation to other countries as well. So there's a great opportunity for learnings. Even, of course, we have a different state of epidemiological and health system transition. We are somewhat behind the US, even in epidemiological transition. And certainly our health systems are not as well resourced as your health systems. But we are moving in the same direction. And as the Portuguese writer Miguel Targo said, universal is local without the walls. So we will have local knowledge and local applications, but that without walls separating the diffusion of knowledge.
Follow on one point that you made there about communities and communication with communities and outreach within the communities. In the US, there's a distinct difference between rural communities and urban communities. Can you comment on sort of the comparison of how India has approached really informing the healthcare consumer in ways that promote the healthcare system?
India, actually, the primary healthcare system was mainly designed for rural areas. Surprisingly, urban primary healthcare was neglected in the naive assumption that adequate number of doctors would be there and educated people in urban areas would be able to look after their own health. However, even the rural primary healthcare needs to be improved, but community engagement has been a feature of primary healthcare in India, and it has improved further with the National Rural Health Mission, where there are definite mechanisms for involving the community, not only in terms of improving community health literacy, but also engaging them in monitoring the programs and even looking at how the programs are delivered. In different parts of India, women's self-help groups have been energized and empowered to actually undertake some of the health component also, apart from the microfinancing component. It is in the urban area that we have seen urban primary healthcare has not really made a headway, and we need much more. I think the sense of the community is also better in the rural areas, and therefore that's been. Tribal areas, of course, remain a weak area for us in terms of our penetration of health services, but that's another area we ought to look at.
To comment at all, sort of as a counterpoint for some of the observations in the U.S.?
So I think your comments about physician assistants is a good one. We actually have started a physician assistant program at Tufts, and we take 50 students a year, and it's a 2-year program, and then they go right to work. But they work under a physician, they're assistants. So they learn much of what they're going to learn on the job, which is how we learned as well. So that works well. But I think this issue of the difference between urban care and rural care is a universal one. I see it in every country I visit. Doctors like to live in cities. They like to live with their good schools. They like to live with this culture. And it's hard to get them to live in villages, whether it's in America or whether it's in India. And I think we really need to all be thinking about how to reorganize primary care so that we can do it in teams led by a doctor, but using ancillary help. India's done a good job using community health workers in many areas. So physician assistants would fit into the middle of that range and could certainly add to it.
Before the recent collapse, before recent problems, Brazil had the best example of family health teams. One doctor, one nurse, one community health worker for 150 households, and supported by teams of dental hygienists or dentists, if available, co-located. And 4 to 5 of the family health teams would be supported by psychologists, community pharmacists, and by physiotherapists. And I think that's the kind of model that we really ought to be looking at.
Honorine, I would ask, you have a unique perspective here because you both exist in the U.S. system and at CMC. Do you have observations that are informed by the fact that you kind of go back and forth between the two systems?
I think, having lived in the US for far longer than I did in India, I see that, the issues in the US with healthcare and health insurance, and at the time that I lived in India, there was more health insurance, basically. Paid yourself or somebody paid for you. But I know there have been a lot of issues about health insurance in the US, but there are a lot of good things as well. So that's my perspective. I mean, would I rather, if I had cancer, would I rather be in the US? Or would I be in India where there's, if I couldn't afford it, there's no health insurance. And here, I do have health insurance, so have access to much better care. For the major diseases, but I think for everyday diseases, the healthcare in India has got if not better than in the US, so they have insurance.
Much. So the next question that we thought would be a good continuation of that discussion is really how now are the recent reforms and healthcare initiatives addressing some of the challenges, and the challenges again that we've talked about are the magnitude of the need for healthcare delivery both in the US and in India, the differences between rural and urban, or even just between states with different customs and resources, as well as then this shifting burden of disease from communicable to non-communicable diseases. So how do you see then recent reforms and health initiatives beginning to address some of these challenges?
I think Srinath has already explained why Ayushman Bharat does tackle some of those gaps which were identified. Insurance does, because it covers all different kinds of diseases. It's also covering the NCDs, which is now the largest source of this burden. But I think, as an economist and as a public policy enthusiast, I think I'm just happy that health is finally a high priority in public policy in India. Because while we've had reforms, health has not become political the way perhaps it is in the US, where people are voting, citizens are actually voting based on health issues. Unfortunately, in India, that has not become a case yet, and I think there is absolutely a need because public health is the core of our healthcare system. Despite the fact that 75% of healthcare is private, but public health has to be, even in the long term, particularly the preventive and the primary component of it is very much the job of the government, because we know markets do fail, particularly when you get down to preventive and primary care, because the margins are so small. In fact, the innovations that we have been seeing from the market perspective, a lot of those innovations are mostly for the secondary and the tertiary care sector. And in fact, that's the reason I think India has one of the fastest growing super specialty hospitals which cater to medical tourism. It's again one of our fastest growing sectors within the economy, and there's a reason for that, because the economics of that lends itself to this kind of innovation. The primary space, however, it really has taken champions, and we have some in the room other than Srinath. We have Poonam here. We have people who have championed the cause of public health and primary care in particular, where the government role cannot be abdicated. And again, I keep reiterating the same point, that there is a central government which can perhaps highlight and bring out these large policies from the central, but eventually a lot of the implementation and the provision and the delivery of healthcare is a state subject. So it rests upon the communities to then provide this kind of care. Another point, and this is the rural-urban divide. I think it is. You're right, Harris. It's a global problem, rural-urban. But in India, it gets accentuated further because more than 75% of our health infrastructure is urban. And India, while it is urbanizing very fast, almost 50%, 55% of the population still is rural. And that means increasingly the cost of hospitalization is, because of the travel and the uncertainties, the logistics involved, it's just that much more of a burden on the household. So there is a need, therefore, to address the local needs through the public care. And that, I think, is again the role of the government. Now, one statistic, and this is a fact which for me is very telling, is, you know, even in terms of how many sub-centers, which is the first point of contact of a citizen to the public health infrastructure, which is called a sub-center. And then for 30,000 people, we have a primary health center. All those benchmarks, population benchmarks, actually only exist for rural population. We don't even have those population benchmarks when we look at urban areas. And that sort of tells us that the kind of blind spot we've had when it gets to urban poor in particular. So I think there is still a lot of work to done, but I'm very happy that Ayushman Bharat, because of the political patronage, is finally making healthcare political in India. It's a good thing.
Honorine?
So just to address the issue of urban versus rural, again, it's a global situation. But in India, in the urban areas, you have the huge slum communities, and studies like in Vellore, there have been studies done showing that the urban slum dwellers are much worse off than those who live
In fact, that's true of Delhi as well and the neighboring states. But one of the issues that we have not really talked about, the problem of migrants. Again, there is a huge amount of rural to urban migration for employment mostly, but also for education. And there are a number of the slum communities and low-income communities which form because of migrants. There are also seasonal migrants. So, but particularly their healthcare requires attention, and they often do not have sufficient civil registration status to approach their healthcare facilities. And this also introduces one more element. Any insurance program or health cost coverage program has to have portability across the country. If somebody who is from Odisha moves to North India for agricultural work or construction labor, that person needs to be covered. How? So these are all some of the elements that need to be built into the reform process.
So if I may go back for a moment to the slum communities, I'm curious, has infectious disease in those communities maintained its dominance in terms of the most important source of disease? I would assume so. And if so, do you see the new healthcare initiative as being able to make inroads into that, given what we know about infectious disease?
Speaking about Vellore, because that's what I know the most about. Infectious diseases are, still predominant, I think. There are some non-communicable diseases that are sort of, I wouldn't say specific to, but are becoming increasingly common. So diabetes, for example, India has the highest rate of diabetes. But the type of diabetes that is seen in the slum communities and in the rural areas, in Vellore, for example, is very different. So they call it malnutrition diabetes or lean diabetes. So they're not, typically the typical patients that you see with obesity and other associated conditions. But these lean diabetics or malnutrition diabetics, they very quickly become insulin dependent. And that is a huge problem, in the all over, but particularly in the rural and urban areas. So, an endocrinologist from CMC, Dr. Nihal Thomas, he actually came to the US and testified to Congress about this new type of diabetes that is, being increasingly seen. And this occurs, in the rural, in the urban, all the communities.
In the slum communities, certainly drug-resistant tuberculosis is a major problem, but you also find high levels of tobacco consumption, substance abuse, and third of the patients are what we call thin dialysis.
It's very interesting. Harris, anything to add? Shamika? No? Okay. So a comment, Professor Reddy, that you made about the, especially the migrant population and the need to have access to the system for those individuals be accommodated in the system. How similar are your states in terms of their relationship to the federal program? The reason I ask that is in the U.S., the difference between what Massachusetts offers through the affordable health care and what Texas offers is dramatically different. And so how much autonomy is there across the states for either core service or beyond?
So I think it's interesting that Srinath mentioned Odisha, because that is the state which has refused to join Ayushman Bharat. And of course, we are in an election season, so there is a lot of posturing that is likely to go on. There's also a one-upmanship because the federal government's Ayushman Bharat has a coverage of 5 lakh, and Odisha, I think it was a month after the Ayushman Bharat was announced, they raised the coverage to 7 lakhs. Now, if you look at the cost to coverage, and I think this is where we have to look at the existing evidence from the experiments of some of the states in the last 15 years. In fact, publicly financed health insurance scheme started in India in 2003. It started with Karnataka, and then Andhra Pradesh took it to a completely different level through Rajiv Arogyashri program. What we learned there is that while it was meant for the poor, and by the way, Andhra Pradesh at that point is like the IT hub, pharma, insurance business, one of the fastest growing states of India between 2000, let's say 4, 5, and 9, 10. And when they rolled out this health insurance scheme, more than 80% of the population was eventually covered, because that's the nature of leakage in the system. Targeting has always been such a big problem that programs which are really meant for the below poverty line or the poor in the country, just targeting is very difficult because of just the nature of poverty, that you have a population which is constantly going up and down. You know, they fall below poverty and then they're above poverty, so there's a lot of seasonal nature to poverty, but also just targeting. Targeting the poor is an extremely difficult problem for the state. So 80% of one of our most affluent states at that point was poor because they could avail health insurance from the government. But what we have learned through these experiments is that there can be early warning systems. They have used smart cards and IT system. In fact, they have an excellent HMIS which was adopted way back in 2007 itself, which has helped detect a lot of these frauds. Now, of course, the politics of it meant that you did not go back, you did not, you couldn't take the benefit away from anyone, but they have managed to reduce costs over time. I think there is a lot of lesson from some of these experiments that we've had as far as the larger, the Ayushman Bharat of the National Health Protection Scheme that we have today. But one component I think doesn't get that much media highlight, and it really ought to, which is the 150,000 primary health centers which are meant to be created as part of this scheme. And that really, to me, is the bigger innovation, because there is a recognition in the system now that this early gatekeeping is fundamental to lowering costs in the long term and to improving access to affordable care close to where people live.
Anyone else? Okay, please.
I wanted to bring up the paper that you talked about differences in states and ratios of communicable versus non-communicable diseases. And I wanted to ask Dr. Reddy, why do you think that is, and does it have any implications for healthcare costs and interventions?
It is definitely something to do with the pace of development. Most of the states are socio-economically less developed than the states which are well advanced in health transition. Also, it has something to do with nutrition transition. The diets are different in the Northeast, for example, from Southern India or Western India. So basically, we are looking at demographic transition, nutrition transition, and very importantly, developmental transition. and therefore the pace is fairly varied. India exists simultaneously in 3 centuries, and therefore you will find different patterns of disease. But the direction is very much the same. In every single state in the last 25 years, we have seen a rise in the proportion attributable to non-communicable diseases. But the manifestations will vary. Like, for example, as blood pressure rises in rural areas and states which are early in transition, it will translate into bleeding stroke, hemorrhagic stroke. As smoking, diabetes, and fat-rich diet, it becomes a clotting stroke, and then finally into heart attacks. So you can see these variations in the pattern, and we are seeing them very clearly. But we are also seeing a compressed epidemiological transition. What took the United States almost 100 years is taking us 20 to 30 years.
Thank you.
So you, Dr. Reddy, you had mentioned earlier that the rural health care, primary care, is better than it is in the cities. And I think the fact that you have rural centers and that there are no other choices for people is probably good. We have an experience, Debbie mentioned that in Massachusetts, that the health insurance system is much more generous than it is in some of the southern states, including Texas. As we expanded the care for the poor, one of the things that we were hoping would happen is that they would stop going to hospital emergency rooms every time they had a minor illness, because that's the only place they could go before, because now we've assigned primary care doctors to all of them. Turns out they still go to the emergency room. They're so used to it, you can't get them to change that behavior easily. So behavior change is difficult.
But at the same time, you've seen the emergence of urgent care centers. So some innovations in between the ER and your primary care doctor have been important. I'm keeping my eye on the clock because I want to leave plenty of time to have questions from the group. I still have a couple more, but so I'd like to open the floor at this point for any individuals who might have questions.
I'm Mudit Kapoor, Professor of Economics at Indian Statistical Institute. I had a request actually from one of the panelists to emphasize a public policy issue that she has done a lot of research on, which is gender discrimination in access to healthcare. I think more than the urban-rural divide, there's a huge gender discrimination, and one of the panelists' work research, whom I'm privy to, has for the first time looked at very individual level data, and I think it would enlighten us a great deal if you could comment on that. And the second issue, I think, which I would urge the panelists to also think the public policy challenge, and this is also to Dr. Reddy and Dr. Shamika Ravi, is measuring health issues. We don't have in this country adequate measures of healthcare. For example, at the district level, I can't tell you how many children are dying, what is the neonatal mortality rate. And that too, at the state level, we at best have good estimates of it. I've looked at the global burden of disease. It's not really a reliable story. It's not telling us a very reliable story of what are the transitions that are happening in India. So I think measurement of health should be considered also a public policy challenge. So would like to get comments from two of the people, because her another research is also on CRVS, where she's just trying to measure how many kids are dying and are born in a district level. So I would like to get her comments on both those research. Thank you.
Okay, well, he's the co-author on both those studies. So I do owe it to my co-author, but also it is true that gender and health have a very toxic relationship when it comes to public health in India in particular. There, if you look at access to care, we have access to data from All India Institute of Medical Sciences, which is India's apex public health hospital. In fact, it is Asia's largest public hospital. AIIMS is really like 7 mini, and of course I shouldn't be talking about AIIMS when Srinath is here. He was the head of cardiology there and can speak much more about the institution. But AIIMS is unique because it is really a conglomerate of 7 mini hospitals. And there is tremendous amount of data that the AIMS HMI has put in place. And the first thing when we started analyzing some of that data is just simple things like the sex ratio of the patients. And removing gynecology and obstetrics, if we just look at the probability of accessing care conditional on having similar morbidities, we see that 40% of female patients are missing. So it's not a cost issue because the costs are very similar. This is more of a societal problem where when care is available and households do avail it, there is a tremendous gender inequality or a discrimination that is happening at the household or the society levels. But that's the average number of 40%. If you actually look at the age profile of it, then we realize that households are actually quite rational in a very morbid way. Young girls and old women are almost never brought to tertiary care, even if it is free. So most of the time, the women who are being brought in for care, again, removing gynecology and obstetrics, so the data really involves all other departments, you are most likely only going to see women in their reproductive age group, and it is not for reproduction. So that just tells you what the utility of women and the way public health is, is perceived, and how public health is even accessed in the society. So one element of it is what do we do as public health professionals in terms of understanding, improving affordable care. The other is really a society problem, and I think that is where when we talk about involving the community, it is a far more entrenched problem that requires a lot more mobilization. So that's from the gender perspective. The other is, the CRVS, and again, Srinath again mentioned it when he talked about civil registration of vital statistics. We are signatory to the Sustainable Development Goals, so on certain indicators we are required to bring it down. The problem is that we really do not have a proper mechanism of counting the dead in India, or even the birth, frankly. But now that we have had this Digital India revolution and we have this great IT promise, and connectivity today is better than it has historically ever been, there is a need to be able to actually count and measure the maternal mortality number and the infant mortality number. In fact, all data sets which are surveys, and if you estimate what the infant mortality and the maternal mortality is from a survey, it is really just an estimate. And different surveys and different estimates are not talking to each other. In fact, there are variations of 100%. So we are basically saying that we have a problem in the form of maternal and child health, but we now need to address public health concerns using IT in ways where we can really establish a civil registration of vital statistics. Also, we now have the Aadhaar system. Aadhaar is really the unique ID which every Indian has today. So we have that platform on which a lot of these new systems of counting of our citizens is possible. So that is an experiment which we are looking to unfold with the help of the ministry and the Home Ministry in particular. But Srinath, if there's anything you'd like to add to.
I think the point is very well made that we need much better, much more representative and much more timely reporting through reliable data systems. But I think the answer is to really reinvent the collection systems from ground level up, with the frontline health workers who are technology enabled, even using icon-based reporting systems rather than pen and paper, in order to generate the data which flows upwards, and have every healthcare facility also present their data. And then we need data which is fairly timely in reporting, so that you can actually mount a rapid response or have a program review. Unfortunately, this is one area where we haven't advanced enough, and given our much wanted strength in technology, this is where we should advance fast.
So I have a question here, and then we'll go back.
Sorry. First, I have a comment. I think in the discussion it would help to distinguish between three uses of the word public. One is public health, the other is health of the public or for the public, and third is public sector provision of health or public sector of health organizations. Because some of the things when you were talking, my comment is, I'm not a health specialist, but recently, last couple of years, I've been sort of focusing from a public policy point of view. And there are two topics which seem to be totally neglected. One is sanitation, and I'm just mentioning which is in some ways the highest priority of this government initially in the case of health. But it's not something that healthcare professionals often deal with. It was Swachh Bharat. Secondly is primary eye care. ODI, I recently read a paper on ODI in the UK, which pointed out that perhaps that's the area of primary health care where there is the biggest bang for the buck. It's totally neglected here. What is the view? But focusing on India and US learnings, the primary centers, which Shamika says is the neglected part of the discourse, but that's where government has, until now, focused all its efforts. The work done mainly by US and Indian economists show they've been a total failure, the primary health care centers. What is there that is going to be different? And this is something I think also the US has struggled with, but let me just give you one simple aspect. Rural healthcare, people talk about that. The US also suffers on those issues, but there have been people have done studies on how the VA, Veterans Administration, made a difference. Also, I know immigrant doctors, people think of them as being in the central, city hospitals, etc. But a disproportionate number actually make their careers in the rural areas. That's the other area where perhaps some lessons from the US might be helpful. Health insurance only for hospitalization. That's what Ayushman Bharat PMJ, that's the insurance component. That creates certain incentive problems. And they are sort of manifold, multiplied, amplified. But if we could just understand the American incentive problems, I think we would realize what a bigger boondoggle we might be entering into unless we redesign. And lastly, it's all coming together. US has actually, I've been looking at what lessons to be drawn. There have been, over the last decade or two, major changes in the industrial organization of healthcare. We are we are seeing emerge in India similar sorts of issues, and once these things gel into place, it becomes very difficult to dismantle the vested interests that get created. What are the lessons US can provide? As far I'm thinking of charity hospitals or for-profit hospitals, not-for-profit. There are 3 or 4 different ways you can think about these things.
Thank you very much. There are a lot of questions embedded in those are great summative comments. So would anyone like to pick up on any points there and add to the excellent observations? Yeah, no, they were.
Don't talk on that.
Yeah. All right, well, thank you very much. And we had a question here and then a gentleman who's patiently waiting behind the podium. So.
All right, my name is Raj Kumar, Vice Chancellor of Jindal Global University, and it's a fascinating panel. And one of the things that I wanted to ask Dr. Reddy, maybe others can share, is that to what extent is part of the problem in India where the medical education and medical schools had been historically divested in not having strong focus on public health education, and the lack of public health schools as an impetus and independent from medical schools itself. Since US has that experience, I would like you to reflect about that, because we have been talking about, I must say that some of these issues we have been discussing for a decade or so, and the real challenge continues to be that we have not been able to create an attitudinal change within India about the need for public health education as significant and important as medical education.
Well, as far as India is concerned, I think we went wrong at the time of our independence when it was decided that preventive and social medicine, which now is also called community medicine, would be taught only in medical colleges. Part of this problem arose actually from the United States. When the Rose-Welch report was submitted in 1912, at that time, Rose argued for independent institutes of public health. Welch argued for embedding them in medical schools. Welch won, and Rockefeller funded Johns Hopkins to start the School of Public Health. And that sort of became also the template for us later on. But the problem in India is much worse than elsewhere because of the regulatory constraints put by the Medical Council of India, where in medical colleges only doctors can teach doctors. So ultimately, even the community medicine departments ended up teaching doctors how to run a rural clinic. But the transdisciplinary breadth of knowledge that is required for public health, for multisectoral application, was absent. Or there were some distinguished exceptions. Of Vellore, St. John's, All India Institute tried to do something. But if you can't employ a health economist, if you can't employ a behavioral scientist, you're actually falling short of many things in public health. And we believe in Public Health Foundation of India, you need public health law, public health engineering, you need public health communication specialists. So you need the transdisciplinary mix, and that's why we also went in for independent institutes of public health rather than linking them with medical colleges. But I think with many universities also now thinking of starting schools of public health, in the university we may be able to bring in more of the transdisciplinary thinking, and hopefully the medical schools also should follow suit.
So America is sort of schizophrenic on this. Although the schools of public health are the ones who get all the press, about half of the masters in public health degrees are given by medical schools. So in Tufts' case, we have a department of public health that's part of the medical school. And we think that that's important because we want them to understand that medicine and public health are all tied together, and we want our medical students to understand that too. And we actually have a joint program where students can choose to get an MD and a master's in public health degree in the same 4 years. And over 10% of our students choose that every year. But the important part is those students have a profound effect on the rest of the students because in their classes they ask questions that are from a public health point of view.
So I would be remiss if I didn't add that we also have dual degree students at Tufts that are veterinary students and public health students. Same program with the medical students. The concept of teams, which we talked about earlier, and the idea that it's a health professional team, especially in rural settings often, where animal-human interfaces are very important to infectious disease. I think all those things work together and are really important. And so now, the gentleman behind the podium. And
Rocco Weglars, formerly with the Australian Government, now Geneva Centre for Security Policy. Thank you for a fascinating discussion. I've learned a lot. Apart from the issues that have been raised already, two issues stuck out for me. One was lean diabetes, which I hadn't heard about. So if somebody could talk a little bit more about what are the causes, is it genetic, is it diet, is it pollution? I just don't know. This is something completely new for me, so thank you for raising that. And the other one is in relation to where the poor rural people are currently spending their money. There is a big competitor. It's the so-called traditional, so-called alternative sector, which is huge here in India. It's bigger than anywhere else I've seen. And the poor choose to spend their money there on healthcare that is actually quite bad and doesn't work. But then that's contrasted against a public system, and all the independent evaluations I've seen says that's also really bad and doesn't work. And a lot of the time, the people who are paid to be there are not actually present. At least with the fake medicine, you get some care and concern. You don't even get people who are being paid to be on the job, in those jobs, at the moment. And this is the sector that the Indian government is now looking at massively expanding, which will accentuate all the problems that are already there. So some information, please, on the first question, and some commentary or correction on the second. Thank you.
Briefly on the lean diabetes issue. Firstly, there is a thing called the Barker hypothesis, which has had a lot of proof used, in which if you have intrauterine malnutrition or early childhood malnutrition below the age of 2 years, and then later on even normal nutritional supplementation can lead either to a stunted obese child or even without stunted obese. Even if you gain weight, it is mostly in the form of fat rather than lean muscle mass, and most of it is deposited in the abdomen. You can be thin, but you can still have a lot of abdominal fat, and that's metabolically different. So we call it metabolic obesity rather than obesity. So they are much more likely to develop early diabetes and early cardiovascular disease. And much of the problem could be attributed to that. Then the second, of course, the whole issue of microbiome and other things comes in. And this is not really genetic in that sense. It is epigenetic. this is modification of gene expression by this kind of nutritional influences rather than gene structure itself. So these are some of the, and pollution of course is another aggravating factor, because pollution also causes epigenetic changes, and we know now that pollution can actually cause diabetes, metabolic syndrome. So we know that too. Regarding the question of public sector, clearly one of the problems is that people who are employed in the so-called public sector hospitals are not really working full time. Only in Delhi they do. Most other places they actually are allowed to do private practice, and they're hardly available. So the solution there is not just to ban private practice, but increase their salaries and give them sufficient incentives for their career progression, so that they will actually devote more time to their work. And that is where you require more public financing. If you limit public financing and expect the doctors on very low salaries to work full time, they're not going to be working full time. So you're creating a perverse incentive for them to go into private practice.
I just wanted to add that lean diabetes or malnutrition diabetes or whatever you call it is seen mainly in resource-limited countries. So it's likely that environmental contamination, changes in the microbiome, nutrition, those are factors that may be implicated in the pathogenesis of it. But it's a very poorly understood syndrome at this point. But there's an organization called the Global Diabetes Initiative that is actively working on trying to look for causes.
So we'll take one more question. We're just about out of time.
Thank you very much. Thank you for all the comments, very, very, very substantive. And there's one point which you might have mentioned earlier. I apologize for being late. I might have missed it. Dr. Reddy did mention drug-resistant TB. But antimicrobial resistance is something which is spreading. It's a major issue. And in that context, amongst the various factors which aggravate it, I think the role of pharmacists also becomes very significant. And we can take care of our population through diabetes, etc., but the infection which is rising due to pollution as well as other aspects, combined with antimicrobial resistance at the large scale at which it's existing and increasing, is there something which is being done? And whatever is being done, is there a role for pharmacists in that? Because whatever I have understood of the issue is that you cannot solve it without the cooperation, collaboration of pharmacists. Thank you.
Clearly, you require prescription practices of doctors to be changed. The adherence of patients to prescribed medicines also to be much more disciplined. But the way a lot of antibiotics are sold and dispensed even without appropriate prescriptions by pharmacists over the counter, that is a major problem, and that needs to be taken care of. One of the previous health ministers, when this was raised, he said, at least the pharmacist is giving something to the rural patient. Why are you trying to prevent that? But I don't think that's the way to do it. I think firstly, if we actually build our primary healthcare much more strongly and dispense medicines there, at least we'll be able to have some control over this kind of problem. But pharmacists do need to be educated, to be regulated to the extent possible, and we need to improve our IT systems. But one other area that we have, there are many reasons, of course, why antimicrobial resistance emerges. One of the biggest problems is also the use in veterinary, not only medicine, but in animal breeding. And that is one area we are unable to control. And that's a huge problem there.
So I would just comment, we also have trouble controlling that in the US, and the FDA has recently increased the regulation on veterinarians to make them liable when antibiotics make their way into the food supply, milk, various meat supplies, even more than they were in the past. So it's a good point. All right, well, I would invite you all to join me in welcoming, in thanking a very distinguished panel of discussants. think the command of data and statistics and these issues is tremendous, and so it was an excellent discussion. I'd also like to thank our host and Brookings India for having us here today, and enjoyed very much the discussion.